Dr. Stella.
Yes, hello.
Hello, Dr. Stella Major. Just take your time, put your slides up until I go through your introduction. So Dr. Stella Major is a fellow of the Royal College of General Practitioners in London, England. She's an associate professor of family medicine, a medical educator, and the director of the Clinical Skills and Simulation Lab at Weill Cornell Medicine in Qatar. Since 2017, she's a certified healthcare simulation educator by the Society for Simulation in Healthcare. Her areas of interest include curriculum development and learner assessment, especially in the realms of clinical and communication skills. She represents Cornell in Qatar's Interprofessional Education Council and is one of the lead faculty supporting IPE and IPC in the primary care setting in Qatar. She leads an AOC lab in technology, enhanced medical education, specifically looking at the use of virtual reality in perception of empathy. Her latest publication on WebOSCE methodology using Zoom enabled remote experiential telemedicine encounters, which was used in a newly created bi-campus elective, which she sponsors, titled Telemedicine Communication Towards a Meaningful Virtual Connection, in collaboration with the Center for Virtual Care at Weill Cornell Medicine in New York. Today, Dr. Major will be discussing telemedicine and medical education. Thank you, Dr. Major, for joining us. The stage is yours.
Thank you very much, Toka, for this lovely introduction. I'd like to thank my panelists. I've learned tremendous amounts from each and every one of you already. And I would like to spend the next 25 minutes sharing what I have enjoyed in both learning about how telemedicine has been incorporated into medical education across the world in different medical schools. And also I will be sharing our own experiences here from Qatar. If you would like to share what you're learning and tweet, please feel free to do so. Other than being the elective sponsor for the bi-campus telemedicine elective that I'm going to speak about, I have absolutely no conflict of interest to disclose. I hope that at the end of this session, you will be able to discuss different ways in which medical schools have integrated teaching telemedicine into the curriculum, and also draw upon this knowledge to apply opportunities to expand teaching telemedicine and learning about telemedicine in your curriculums. I'm assuming that the audience are students and educators and practitioners. So the focus of my talk today really is looking at how we can optimize.
Sorry to interrupt you, but have you shared your screen yet?
Sorry, yes.
I can view it right now.
Sorry about that. Apologies. Okay. Apologies. Okay, sorry about that. Thank you very much, Toka. And I'll start over again. I think I mentioned that I have no conflict of interest to disclose. And my hope is that you will get an idea about the different examples of how telemedicine has been incorporated into various medical schools and what we have done here in Qatar, and draw on that hopefully to optimize opportunities for further growth in your individual schools. And as our presenters have already mentioned, even though telemedicine, learning about it and practice has suddenly become a very sort of hip term, the truth is that it's actually not new, and we've learned from the various speakers that it's been up and running for at least half a century, if not more, in different ways. What I would like to actually introduce everyone to, if they don't know in the audience, is that there is actually an International Society of Telemedicine and eHealth with more than 103 member countries, started off in the early 90s, and is actually a partner of the IFMSA, which I believe the Qatar Medical Students Association is a partner of as well. So for the students in the audience, nurses, physicians, allied health, membership is for free, and they have wonderful opportunities for you to expand your knowledge and understanding of telehealth and telemedicine. So in 2013, the American Medical Association acknowledge the fact that there's a real gap between the way we teach medical students and the way we practice as professionals. And so a tremendous amount of money was awarded to support grants to help schools develop innovative curricula. One part of which is also the integration of telemedicine into the undergraduate curriculums. And what I'm going to do in my future slides is actually talk about some of the schools that have actually been part of this initiative and how they have tried to integrate telemedicine into their curriculum for their students. I'll also bring to your attention that actually to date, there is no national curriculum for telemedicine. However, hopefully, if COVID doesn't delay things further, by the fall of 2021, we should be able to find a national curriculum designed by the task force of the Society of Teachers of Family Medicine. So just be on the lookout for that. Again, I think what's important is to appreciate that with the very rapid evolution of technology, only 50 years ago, telemedicine would have, was much more bulky and less reliable, and is now becoming much more sophisticated and more dependable. And with it also, we heard from our various speakers and panelists that more and more different specialties are actually engaging with the use of telemedicine, as are researchers. And with that, what's fascinating is that, as we mentioned, as we heard from one of our speakers earlier, there are numerous definitions of telemedicine. And in fact, there are more than 100 definitions of telemedicine. So what I would like to do is actually speak to us, focus on this definition fundamentally by Sud et al. So essentially, it is the provision of healthcare services over a spatial distance using telecommunication technology. And the aim is to provide benefits to patients and to society. And it's part of the tripartite mission, improving access to care, making it affordable, and optimizing on quality and convenience. So with that in mind, I'm now going to share with you what I learned about the array of opportunities to teach telemedicine in the undergraduate curriculum. A recent publication, a mixed method study, was based on a literature search as well as emails to 70 institutions that were obtained from the LCME's Continuing Medical Education database. 7 of these institutions interviewed with the authors, and there were a number of peer-reviewed research papers and documents that they drew upon. What I do want to say is that actually the numbers are not so many, actually, and so this actually introduces an area, an opportunity where we should be contributing to the literature. So if we look at the preclinical phases, so 17 of the schools that were studied actually reported a combination of these 4 types of curricular engagement. The majority were engaged in some kind of didactic learning opportunities, lectures. Half of them actually engaged with real patients. Over half, maybe close to 60%, engaged with simulated patients using simulation-based educational modalities. And just under a third of the schools engaged with scholarly projects. And I'll tell you a bit more about that in a moment. Some examples. So as I said, the majority were actually looking at lectures, and the patient care physicianship theme, which tends to traverse the medical curriculum, is an ideal place where telemedicine instruction can be easily sort of fitted in and introduced. Similarly, and we heard from our speakers earlier, where you have interprofessional education and collaborative practice, again, this is a fantastic vehicle to bring multiple professions together and to introduce students to interprofessional education and collaborative practice through telemedicine. An interesting example at Cleveland Clinic, where they've actually looked at the ethics curriculum, and they have brought a patient into the classroom through video stream, a patient who's getting counseling for dialysis. And this really allowed the students to get first-hand view, seeing the patient and the healthcare provider talking about challenging themes around, if you like, sort of complicated ethical dilemmas that patients have to grapple with. In New Mexico, they've been looking at introducing telemedicine and expanding horizons, working across different countries and actually doing some global health projects. And finally, at the Oregon Health and Science University, they've been engaging with telemedicine, objective structured clinical examinations with feedback from simulated patients. So here's some numerous examples of the preclinical integration. We also heard from our panelists that the clinical domains are using more and more of telemedicine in practice. And so the clerkships are a fantastic situation where students, when they're committed to their clerkships, can actually be exposed directly through patient care to telemedicine. We just heard about the psychiatry, we've heard about neurology. I'll tell you a little bit more about dermatology, and we've again heard about the radiology use as well. What I found particularly interesting was number 5, where there's actually a telemedicine clerkship, and the students in their 3rd and 4th years at these universities are basically acting as the liaison. So they are connecting the medical teams with the families, creating virtual rounds, which I thought was a very interesting way of really trying to make the system come together. And I imagine they would have learned tremendous amounts from that. I've just pointed out here that the emphasis can really be either in regards to patient care or in regards to the core competencies of telemedicine per se. Either way, medical students have found this an invaluable experience. It's been reported that they feel much more familiar both with the technology and with the possibility of incorporating it into their future career choices. So very, very important for us to make sure that we provide our students with optimal training. So here's another interesting study where they have dermatology residents. They do daily teledermatology consults with their faculty member overseeing their clinical decision-making, and medical students were actually observing this process. When they had a look to see what was the observed opinion about the learners, we see here that 88% of the medical students in this study were very happy with this as an important educational tool. The authors are suggesting that the sooner we start, the better it is. To the right of the screen, we can see that there are some important core competencies that are being fulfilled, such as providing care to the patient, number 1, but also increasing the knowledge in regards to dermatology, for example, both of the students as well as the residents. And this is a fantastic way of teaching students and trainees about systems-based practice. And finally, in a very rural part of the US, an interesting study where after a 2-day telemedicine education program, medical students were assessed on their knowledge and understanding of telemedicine, and clearly that was improved, as was their interest in opportunities within their educational spectrum. What was interesting for me also was that when they were asked to see if they would be interested to engage in the rural setting in telemedicine hubs, the response was variable. My guess is that this is probably because they were very early on in their educational journey and probably felt not so confident. Okay, so for the rest of the talk, I'm going to share with you a little bit of what we have been able to do here at Weill Cornell in Qatar. And this really is post-COVID time. So in March, we suddenly had to stop all our in-person teaching, but of course, the instruction didn't stop. And very quickly, I'm delighted to say that my team and I were able to transition from the in-person OSCEs, which are the clinical skills assessment tools that we use at our college, to the remote OSCEs using Zoom as our platform. This was successfully published in the BMJ series, and our students expressed great satisfaction, and they said it was very safe and very encouraging, and overall a very positive learning experience. And our students also themselves having highlighted that this models what telemedicine looks like. Of course, at that point in time, their concern was that they couldn't perform any kind of physical exam. So prompted by their motivation, by our ability to conduct OSCEs remotely, and I embarked upon building really and collaborating with a fantastic team. And I want to say here that to create something from scratch, which is also new to the curriculum, is only possible really when you have fantastic technological support, in-house expertise, fantastic faculty who may not be necessarily experts, but all willing and interested to learn. And we were very fortunate also to be able to collaborate with the Center for Virtual Care, which is a long-standing telemedicine hub at the New York Presbyterian. I'll come back to this in a moment, but I do want to say that it's really important to look around and see what resources are around you and who you can collaborate with, rather than feel that you have to do it all by yourself. So on this page, I will start by bringing to your attention what we have on the bottom of the screen, which really speaks to what Dr. Ujwal was saying, that there is an art to providing a good video consultation, and this needs to be taught just as much as we need to teach good bedside manners and patient interviewing skills in person. And this was one of the, one of the key focuses of our elective. And the title of our elective was Achieving a Meaningful Virtual Connection. We drew on excellent work from the Center for Virtual Care, and the elective started off with a flipped classroom where they basically went through 8 models and learned all about the elements that Dr. Ujwal talked about, which is framing yourself, the light, and the pixels and so on. So very quickly after day 1, our students were very mindful of where they were, what they were doing, how they were speaking, where the hands were, and how quickly or how slowly to move to be able to maintain their connection using the telemedicine platform. At Cornell themselves, they have an elective in telemedicine for residents and also for the senior medical students as well. And they combine that incidentally both with lectures as well as with simulated patient video encounters and feedback. To the left of the screen, I just want to show you, this is the landing page of Canvas, and this is how we created our elective. Everything sat in on Canvas, and it's really, really important. It was in fact one of the positive pieces of feedback we got from our students. The landing page basically provided the students with an understanding that it's a big team affair. This is not a one-person affair at all. So we had our team with a pediatric nephrologist, a cardiologist, a rheumatologist, an ED physician, a librarian, and our team from New York who are emergency physicians, and the clinical skills team. So it really takes a village to make it happen. Our 20-hour remote telemedicine elective comprised of the following main components. So just over half were based on a number of different interactive but didactic sessions through Zoom. And these included an introduction, because we had to start by introducing everybody. We all heard about it and everybody was curious to know, but we needed to sort of start from the basics and understand what is telemedicine, telehealth, and what are the opportunities and the challenges, what are the legal frameworks. With COVID coming on board, suddenly there had been a huge shift. And so we needed to know what it was the pre-COVID, what is the post-COVID, what technologies there are. And we invited also a provider from Qatar, and the students had an opportunity to hear firsthand the experience of one of our providers. And we also integrated into this an introduction to formal recognition of health literacy. And this is really important, because one of the key things that one has to be mindful of is the way we make clinical decisions when we are consulting with a patient remotely, and recognizing their health literacy gaps and being able to adapt to those gaps is really an important skill, which we were very fortunate to have been able to incorporate into this elective. through Zoom in our interactive platform, and that was another amazing thing because we hadn't done remote courses either, but through Zoom we were able to design and build some interactive workshops, and we introduced the students to the Academy of Communication and Healthcare Toolkit, which is a fantastic, very user-friendly communication skills toolkit for telecommunication encounters, if anyone is interested in using that. And also we created scenarios to introduce our students to the ethical dilemmas that one can be faced with when you are dealing with screen-based encounters with patients. The second week were actually in real simulated patient encounters that the students had, and they rated very, very highly. And at the same time, through Canvas, they had opportunities to write reflections and provide feedback to each other as well. So a wide array of different educational modalities and objectives. What I would like to do in the last couple of minutes is to share with you the responses that we got from the elective evaluation. So there are really two parts to it. One, it was that we were instructing remotely, and that was a brand new experience. And then, of course, the second part was the content that we were trying to achieve through the remote instruction. Well, it was clearly a very, it was a very engaging opportunity. They enjoyed the interactive parts, particularly the workshops, particularly in the simulated patient encounters and debriefs. And they were very happy that they didn't have to commute. Those who are in Doha, interestingly enough, we actually had some of our participants who are also outside Doha. So we were really doing the remote learning from remote destinations. The comfort at home was something that came up when they were talking about the ease of talking to patients. They just felt like it was so much easier than if they were sitting in the clinic or in the clinical skills center for that matter. They also expressed that it was really valuable to be able to have international faculty teach them, and agreed that relying on international faculty to be physically present is much more difficult. So yet another beautiful example of how remote instruction can open doors and make us learn from each other no matter where we are. And despite all of that, so with their biggest concern was how will they communicate with the patient through a remote platform, and really they felt like this was something that they achieved. So I just want to draw a quick comparison here. This word cloud on the left actually was created when we asked some students to put together 3 words that they thought about when they thought of telemedicine. And very quickly, what I want to say is how much it resonates with the themes of remote learning that we talked about. So we're remote learning, but we're also remote, providing care remotely as well, and we're learning. So many, similar things like convenience, access, new, future, evolving, fast, and simple, interestingly enough. So, as with everything, we need to know what we should do more of and what we should improve on. And so again, I'm delighted to know that the learning management system was found to be of great value. And I would say to all students and educators out there, really get to learn the learning management system of your institutions. You can do wonderful interactive workshops, particularly. So Zoom has been a brilliant thing for all of us. We've learned from it, and I'm sure that with COVID being here, we will continue to be very much connected to this. I'm delighted that our research was integrated effectively, and the web-based simulated patient encounters provided the students with a real opportunity to do some remote consulting. And again, they enjoyed the workshops and the diverse faculty because we all brought different perspectives to the discussions. So what they wanted less of, rather, were fewer didactic sessions and more discussions, more discussion boards, more peer-to-peer feedback. A couple of times we ran over time, and that was the key thing that they reminded us not to. And of course, 2 points, and I think one was raised earlier in the rehabilitation, was, how are we going to learn, how can we do physical exam remotely? So people are curious to know, we can do the communication, we can do the listening, but how are we going to do the physical exam? I've listed here a series of things that our participants gave us feedback on having acquired. And what I really want to do is just to say how broad and how, I think how rich the learning was based on what they have told us, from the technology all the way to the ability to communicate and convey empathy through a screen, to the ethical frameworks, and to the application of telemedicine in the current and future healthcare systems, both in Qatar, the US, and our participants from Peru and Korea also did their own research. And so we were suddenly learning about the telemedicine globally. I also would like to share the skills that the students felt they had acquired. And it was really very important. They made specific note about being present in the encounter and drew on how different it is, when you're sitting in front of a screen, to being really present versus when you have a person sitting, by you and you're present. They talked very quickly about what Dr. Ujwal mentioned about the environment, the light, and how to present themselves professionally, how to engage with people virtually, how to make clinical decision makings and clinical management plans when you're not sitting next to the patient. And finally, how to assess and improve health literacy of patients. And I like this particular feedback because it really was drawing on the fact that what they've learned through telemedicine actually is very much akin to what they will be practicing even when they are in an in-person setting. It was very encouraging to see that we had students who felt that we had covered a great deal of what they had hoped for and were even feeling, I dare say, prepared to conduct telemedicine encounters themselves. Therefore, in summary, I would like to make the following few points. We've heard from our panelists, everybody's, COVID has accelerated the trend, but there is plenty of telemedicine actually in practice. And it is now the time for us as educators to make sure that we can leverage, our trainee physicians can leverage technology effectively so that when they are in full-time practice, they are able to run with it. One size doesn't fit all. There are different schools, different ways, different resources. I think every school needs to think what they can do, how they can offer, who they can collaborate with. No need to reinvent the wheel. Look out for telemedicine institutions and super hubs, collaborate with them. Integrate, so none of us have extra time really. This elective was an opportunity for us to offer because the students were still studying in a remote setting. They couldn't come back and join their clerkships. But realistically speaking, there's no extra time in the curriculum. So the smartest way to integrate telemedicine would be into existing courses and competencies where it actually speaks to the nature of the discipline. From the teledermatology study, we learned that the earlier we introduce it, the better the learning appears to be. A number of articles and a number of authors have expressed the importance of making this an integral thing, not just a one-off and the students are introduced and that's it. It really needs to become integrated into the innovative curricula that we are running. And finally, as I said, we should all be on the lookout from the STFM to see what the what the national curriculum would look like. Here are my the articles that I've drawn, and I'm very happy to take questions. Thank you very much.
Thank you, Dr. Stella, so much. That was an excellent talk about training the future generation of doctors. I have a question here about what do you think students found most difficult when learning telemedicine? Is it the technology or the website manners or physical exam?
So what the students found most difficult? Mm-hmm. Now, I don't think that, I didn't really hear them say that they were struggling with the technology. I think they found the technology piece fascinating. The lectures that we had on the opportunities and the new telehealth app, instruments and so on were really very fascinating. So I don't know that, and of course at this point it was an introduction. So it's not like they were utilizing the apps, they were really being introduced to them. So I didn't feel that that was a challenge. I think probably their biggest concern before they engaged was actually in talking to a patient remotely through, doing like an OSCE but on a screen. And they're concerned about how can they show, empathy, how can they be, how can they express concern for the patient. One of the examples being that if I want to reach out and place my hand on my patient's shoulder, I can't do that because the patient and I are, basically apart. So I think he was really more the concern about how can we keep the humanism in the communication, in the encounter when we have a screen between us.
That actually answers the other question about if you've noticed any difficulty with students establishing rapport with the patients, through a virtual platform versus an in-person one.
Yeah. So, what was quite interesting was, once they were on day one, they learned everything about framing, where to look, how to do, don't move too quickly because it just causes more, distraction. And so suddenly they were so aware of the way they were presenting themselves that I think when it came to the actual encounter with the patients, they had already, they were better versed with it. I think let me share one other reflection. So coming up to their first OSCE, they all admitted that they had spent tremendous amount of time making sure that the camera was at the right place, the lights were at the right place, that their badge was high enough so they could show that who they are, and the mic was not disturbing the badge and so on. And so there was a tremendous amount of effort that had gone into it to make sure that they appeared professional. And then the funny thing is, once they hit the encounter running, all of that was forgotten. So, a big learning message, big learning point was that once you've got a sense of, the few things that you need to be mindful of, then you can engage with your patient, really quite easily. The technology stops being a problem.
And one last question for students that don't have access to a telemedicine elective as organized as yours. With what resources can they use to sort of prepare themselves for the telemedicine experience? For example, if there are any courses available?
Yeah, so, and thank you, Toka, very, very important. I think, not knowing who my audience is, I was hoping that there would be some educators as well. The thing is about the students, I would say, come and ask us. It's really when you ask your faculty for your needs, then we can help you find ways to provide you with those needs. And the international society that I flagged earlier, this, I would suggest that everybody looks at it. They have lots of, webinars for all types of audiences. So there's probably more out there than we know. But if in doubt, ask your teachers, ask your colleagues, and you may find that there's actually an interest there, and you can just, kindle their enthusiasm. I'm also on this moment, I'm very happy if there are, colleges and colleagues around who are interested in knowing more about what we've done. I'd be very happy to share and communicate with them.
Thank you so much, Dr. Stella.